Okay.
Uh,
Yeah.
I'll just skip to, this is Journal Club 5. Priya's going to do the main presentation. I'll still be doing the beneficence portion of it, but yeah, we'll get started. I'll let Priya share her screen.
Okay. Cool. Hi, Carl. I'm Priya, if you didn't know my name. Oh, there's one more person. Okay. Let's see. Let me go to slideshow. Okay. So I'm presenting on this paper that was, I guess, published early this year. It talks about, or it's from a research team that's publishing on the clinical efficacy and safety of this gene therapy trial for sickle cell disease. So, which is exciting.
You don't have to hear this.
Okay, so a little bit of background. First on the red blood cell. So the red blood cell, it's the most abundant cell in the body. It makes up over 80% of all our cells. And it has a biconcave disc shape, which is unique because this shape optimizes, it essentially it increases the surface area to volume ratio by about 1.5 compared to like a spherical shape. And so this shape and a red blood cell's deformity is crucial for its function. So a red blood cell has no nucleus or other organelles, actually a pretty simple cell, but its primary function is transporting oxygen and carbon dioxide around the cell. And it can do this because of hemoglobin, which red blood cells are chock full of. And so, but in order for the red blood cell to do its job, it has to be highly elastic and deformable. It has to squeeze through a lot of narrow openings. It has to withstand a lot of shear stress and turbulence. So, it can't be brittle. And so, and this is why, the shape of the blood cell and any, mutation that affects the shape or the deformability of the red blood cell can really affect its function. So, which is what happens in sickle cell disease. So, how does sickle cell disease change the red blood cell? Really, sickle cell disease, it's caused by the single point mutation, which is crazy. And this point mutation is in the 6th codon of beta globin. So here's like an image of hemoglobin, if you can see my mouse. And it's made up of 4 polypeptide chains, 2 alpha chains or alpha globin, and 2 beta globin chains. And all 4 of these together makes hemoglobin. And the mutation is in the beta globin chain. And it causes amino acid change from glutamine to valine. And this then, essentially what happens is when the hemoglobin, or sickle globin is what we call it when it has the mutation, it polymerizes when the globin is deoxygenated specifically. So when it's oxygenated, it's fine. You can see here. But then when it's deoxygenated, then it forms these, it polymerizes and makes the cell sticky. It causes sickling of the red blood cell, which is problematic. And so, so we see this distorted sickled shape, and really it has a lot of effects on the red blood cell. It shortens the red blood cell's half-life. It increases hemolysis, which contributes to increased anemia. And it also causes reticulocytosis, which is, first, the reticulocyte. It's an immature form of blood cell, but it's enucleated. And you see an increased number of these cells in the bloodstream. And essentially why that happens is because the body is trying to compensate for all these blood cells, red blood cells getting lysed. And so it's trying to produce more of these blood cells, but then they keep getting lysed. And so you end up having all these immature red cells floating around in your blood. And there's also increased inflammation and pain. So red blood cell or sickle cell disease is very painful. And this is because of vaso-occlusive crises. It it's very damaging to tissues as well. And this is because, these cells are sticky, right? And they can go get stuck somewhere. It cuts off circulation to some tissue. And the infection, so there's increased infection mainly because of functional asplenia, which is impaired spleen function. It affects the function or the filtering function of the spleen, which can increase infections. Increased stroke also because of the stickiness, and acute chest syndrome because of the same thing, and organ damage. So how is sickle cell disease managed? Really, there's many different ways to manage sickle cell disease. A lot of the drugs are targeted to decrease inflammation, increase the affinity of oxygen to hemoglobin, which then, as I mentioned earlier, the oxygenated form of hemoglobin doesn't sickle. It's the deoxygenated form that is sickled. And so a lot of drugs also target reducing oxidative stress to reduce inflammation, reducing the adhesion or the stickiness of the cells. And all of this is targeted to decrease the vaso-occlusive crisis, which is really the, I guess, main consequence of sickle cell disease that a lot of patients struggle with. And the main standard of care for sickle cell disease is hydroxyurea, which is a drug that increases fetal hemoglobin expression. And I'll talk more about why that is used to manage sickle cell disease, but it's kind of cool mechanism. So more about therapeutic approaches. Obviously, as I said, sickle cell disease is painful. So there's, drugs you can use to relieve pain. Hydroxyurea, as I mentioned, it increases fetal hemoglobin expression, but a lot of patients don't respond to hydroxyurea, which is problematic. A lot of patients need to get chronic transfusions because of how severe their anemia is, but then they're often at risk of iron overload and also transfusion-associated infection. And, management is not really, the final step, because, management doesn't halt the progression of the disease itself. And so really the only curative treatment that we have right now is stem cell transplant. But then even with stem cell transplant, it's not applicable for all patients. It's usually reserved for the most severe of patients, generally recommended for younger patients because it's more effective with them. Finding a suitable donor can be problematic. And so that's not available to everyone. And there's also risks to stem cell transplant because you're taking cells from a donor. And so the graft could get rejected. And there's also risk for graft versus host disease. But then, so this is all what we have available right now, right? Management, stem cell transplant. But then what if we could cure the disease genetically at its source, right? Which is what we're doing right now, or trying to do. But before we get there, I want to address something, which is the incidence of sickle cell disease or prevalence of sickle cell disease around the world. In general, sickle cell disease is more prevalent in developing countries where malaria is also more prevalent. It affects about 100 million people worldwide. And a very small percentage of those people are in developing countries. Actually, over 99% are in developed country or developing countries. So it sort of raises the ethical question, which is a hot point of debate right now in this area, is should gene therapy be the focus, for treating sickle cell disease? Because it's not going to be as accessible, right, to these patients, or literally a majority or most of the patients who suffer from this disease. So at this point, I was going to open out to, do you guys have any thoughts on this question?
How effective did you say gene therapy was for treatment?
Say that again.
How effective did you say it would be?
It is very effective, which we'll talk about. Actually, like this paper that I'm going to go through, it's about one of the trials, and you can see how effective it is, but it is quite effective.
Okay, so I mean, if the ethical question is if should gene therapy be the focus for treatment, then, well, obviously if it's very effective, then you can, but also you have to think about like how expensive it is to get across undeveloped countries or developing countries. So, I mean, I guess if you focus on like hotspots in developing countries, maybe then it could become a focus.
Yeah, definitely. And I think the biggest, I guess, obstacle is cost, right? And also just all the medical resources that that you need to have. You know, you need to have people who can perform the procedure. Actually, a lot of the leading hospitals in the US, children's hospitals especially, we get a lot of patients from abroad, who, parents flying over their children who have sickle cell disease, and they fly them over to the US, to get stem cell transplant or, some treatment, right? But then like you would have to be able to afford that. Like you can't do that, in a developing country, or we can't, at least right now. So
Yeah, I mean, my thoughts on it is that if gene therapy is, I might have missed if you introduced an alternative to gene therapy for the treatment of sickle cell anemia. Um, if that's the only treatment, I mean, it's better to focus on that one treatment versus not having any treatment at all. However, the ethics do arise. Yeah, yeah. If you want to keep costs low, especially for the patient side costs, so it's always good to have cheaper patient treatments. But yeah, I think I don't know if gene therapy is the only thing the only thing that's currently being researched or that's currently looks feasible. Why not?
mhm. Yeah. And like a couple things about that too is the debate, at least in the area, it comes down to there's researchers who study hydroxyurea, which is the standard of care right now. It's very affordable, like very implementable pretty much around the world. And but then there are people who don't respond to it, right? Which is the issue. Like a percentage of patients don't respond to it. And so there's this group of researchers who are like, no, I don't want to focus on gene therapy. I'm going to focus on hydroxyurea, right? Which it's going to be useful for over 99% of the people who are inflicted by this disease. And I'm going to try to improve it so that more people respond to it. And then you have the other side, which is actually gene therapy is not just limited to sickle cell disease, right? The reason why there are more, I guess, gene therapy solutions for sickle cell disease is just the fact that it's a point mutation. And it's a great starting point, right? Like we're developing this technology that we can use to essentially cure genetic diseases. And this serves as a great starting point. And of course, costs are going to be high at first, but then the more you work on it, the more accessible it's going to become. And so that's the other side of that debate, essentially. But it's an interesting thing to think about. Um,
Also, if you had gene therapy, you'd be because as people, as the you create more generations, you have less people with sickle cell disease, so then your costs would exponentially decrease, I'd say.
mhm, yeah, and that one's tricky too, because like actually something that has also been talked about is sickle ever going to go away? Like, can we ever eradicate sickle cell disease? Because the reason why the sickle cell trait keeps getting passed on and why it's more prevalent in developing countries is because of malaria. Because if you're a carrier of sickle cell disease, you're protected against getting infected by malaria. Like there's essentially a protective mechanism there. Um, and so, a lot of people have said, well, I think until we eradicate malaria, we're going to still have to deal with sickle cell disease because it's going to keep getting passed on. But yeah, it's an interesting thing. But um, going into using autologous, so HSPC just stands for hematopoietic stem and progenitor cells. So it's like the mother or stem cell or mother stem cell for all blood cells, and they're found in the bone marrow. Um, and autologous just means it's the patient's own cells, so you don't need a donor. So you take stem cells from the patient and you correct the mutation using one of the gene therapy methods, and then you give it back to the patient. So actually, I want to show this figure. There's really two methods. One is an in vivo method where you directly administer the vector to the patient. And the second method, which is more common, is ex vivo or in vitro method, where you collect cells from the patient and then you correct or you isolate just the hematopoietic stem cells, and then you correct for the mutation and or do a transfer in this case, and then infuse it back to the patient. And there's benefits to doing this. One being, given that it's a single gene defect in sickle cell disease, you have a potential for one-time permanent correction, right? You mentioned that. And also, it's not limited by the availability of a donor, which only 14 to 20% of patients have an availability of a donor, and rest of them don't. And so if it's your own cells, you don't, you got it. And so it also eliminates the risk for any graft rejection that could occur from a donor. And so so there is good rationale for using this therapy. And a little bit about gene therapy itself, like what is it, like how do you do it, right? And the main method that I'm going to talk about today is lentiviral vector transduction. So CRISPR is also one method, but with lentiviral vectors, all you do is you're not correcting the mutation, you're just adding a gene, like you're doing gene addition essentially, and not gene correction. So how it works is you have this packaging cell, which its only job is to produce these lentiviral particles. And this contains the transgene, or the gene that you're interested in, that you want to deliver into your target cell. And it also has this, envelope vector, transfer, and packaging vector, and all of these are important for that transduction to occur. And I'll talk more about the vector itself later. But this is the basic mechanism, is we're just adding the gene of interest. We're not really correcting, at least with lentiviral vectors specifically. Okay, so we have this technology, right? So how do we know what to target for sickle cell disease? And how do we know it'll even work, right? So this is where there's a cool story about fetal hemoglobin, which I mentioned earlier. So the standard of care is hydroxyurea, and the way it works is it increases expression of fetal hemoglobin. So why does it work? Like, why does fetal hemoglobin matter here, right? And it's because babies who have sickle cell disease genetically, they don't have the sickle phenotype. So researchers and doctors saw this, right? And the reason for that is because almost up to 6 months postnatally, babies still express fetal hemoglobin and not the adult globin. And fetal hemoglobin doesn't have the sickle mutation. And so even if the baby is born with sickle cell disease, they don't have the sickle cell disease phenotype until like 6 to 8 months postnatal. And so, which is crazy. So it essentially shows that, okay, like if we're able to express some alternative globin that doesn't have the mutation, then we can cure sickle cell disease. And so this principle of, this is what is called hemoglobin switching, or the switch happens, within the first year of when a baby's born. But, we got this idea of expressing an alternative globin from, seeing this in babies. So a little bit of history on sickle's, gene therapy for sickle cell disease. Almost 20 years ago, we cured sickle cell disease in a mouse. We did it in there's two models. There's a knock-in and knockout humanized mouse model, which is essentially, it has the human beta globin gene, and we were able to correct for it and cure the disease. And almost 15 years after that, we had the first trial where we cured the first patient with sickle cell disease. And they used this lentiviral vector that I just talked about. And it's anti-sickling, which I'll talk about a little bit more after. But there was a couple more trials in 2021 where one trial used CRISPR-Cas9 to specifically correct for the gene mutation. And another one where they did genetic silencing of this gene BCL11A, which usually inhibits fetal hemoglobin. So what this does is by silencing the inhibition, increases expression of fetal hemoglobin, therefore essentially curing the disease. And the final trial is the one that I'm going to talk about today, which is with the lentiviral vector and the safety and efficacy of that. Okay, any questions so far? All right, cool. Okay, so now getting into the paper. So what this paper is about this phase 1 or this trial that's in phase 1. And the trial is to look at this gene therapy solution, right? Or gene therapy for sickle cell disease. And the goal is to evaluate the efficacy and safety of this therapy. And what they did in this trial is they had 35 patients who received a single infusion of this LentiGlobin vector. And they followed up with these patients for like 37.6 months, and they saw if it works or not. And the way they did that, again, as I mentioned earlier, they do autologous transplantation of these stem cells. So they take these cells from the patient and they transfuse the cells with the lentiviral vector, which has the modified beta globin gene, which then results or which expresses and produces this anti-sickling globin. So it's a modified beta globin gene, which prevents sickling. So a little bit about this vector. So it's a lentiviral vector, and it's modified from the adult beta hemoglobin or beta globin, and it has this amino acid substitution, which sterically inhibits the polymerization of sickle hemoglobin. So I mentioned way earlier in the background that the reason why sickling happens is because the beta globins polymerize, right? And so with this modified hemoglobin, that doesn't happen because of this sterical inhibition. And one other cool thing about these vectors, the lentiviral vector, is it actually exploits the HIV virus. So the make of it, it's essentially, it uses the integration mechanism and also the envelope of the HIV vector to deliver the gene that you want into the cells that you want. But one important thing you have to do before that is do this deletion. So there's this 400 base pair deletion, which makes sure that anyone you give this vector to doesn't get HIV because we don't want that. So we remove the propagation part and we just keep the integration part where it integrates effectively and expresses the gene that we want. One other thing that this vector has is these LTR, long terminal repeat sequences, that allow us to identify where this is inserted into the genome. So this is one other crazy thing about lentiviral vectors is they don't insert in a specific place. Like you put these into cells, right? And they randomly insert wherever they want, which sounds problematic. I'm sure you can think of a few problems with that, but I'll talk more about that as well. Okay, so the trial design, it was non-randomized, which this is one of the first ever trials on sickle cell disease, and it's a severe disease, which is one reason. It's open label. They deliver a single dose of this vector. And actually, the design is kind of cool because, all the authors had access to data. They sort of kept each other accountable in terms of the completeness of the data, right? And there's also 2 committees in terms of oversight committees. There was a data monitoring committee to review all the safety data throughout the trial, and also this adjudication committee that reports all the vaso-occlusive events. Also, a cool mention of bioethics in this paper. They talked about following the principles of Declaration of Helsinki and also GCB guidelines. So the Declaration of Helsinki, it's essentially list of ethical principles, but mainly focusing on physicians and research investigators and their obligation to research subjects. GCP is more focused on protecting the rights of human subjects. It's more derived from the Nuremberg Code. And so these are some of the principles that they sort of cover in these ethical, in covering these ethical principles, I suppose. Autonomy, beneficence, confidentiality, privacy, of course, minimizing risks, right, while maximizing benefit, and also protecting vulnerable populations. In this study, for example, this is especially important because if you look at the entry criteria, they include adolescents, and children are considered a vulnerable population. They have decreased autonomy compared to adults. And so, you know, there's some more additional steps you need to take in that case. And some other entry criteria that are important, actually all the patients in this trial had the beta sickle trait. There's some other genotypes, but we don't need to talk about that. And they also looked at the Karnofsky performance and Lansky performance status, which they're both measures of functional status of the patient, make sure they can get through the trial. Some other important things, they focus on patients that have failed hydroxyurea treatment, which, as I said, it's the standard of care. A lot of patients don't respond to it. When they do respond to it, actually, they're fine. Like a lot of the patients, they have enough fetal hemoglobin expression where, you know, the disease is essentially cured for them and they don't need gene therapy. But then the people who don't respond, they really do need an alternate, right? And that's true for also patients who don't have a donor for stem cell transplant, because that's also, you know, an approved form of therapy. One last thing is they required a minimum of 4 severe vaso-occlusive events, which is mainly just to see if there is an actual improvement. The severity of the disease is different depending on the patient. And so that just allows for them to be selective of the patients that they take. And here are the treatment groups that they used. One, there was no control group, which is fair. In this case, you can think of, you know, this is a severe disease and they intend to treat every patient, at least in the beginning. And these are still small group sizes at this point. But they did an optimization process where first they started with a small group of 7 patients, and then they improved the regimen, the treatment regimen a little bit for group B. And finally, they ended up with group C, which is what they presented for most of this paper, where they ended up with 35 patients. And I'll talk a little bit more about what changed, because there's a nice table for this, or figure, I guess. I should probably just minimize this. Okay. All right. So, so these are the 3 groups. And one main change is how long the transfusion regimen was before the collection of the cells. And this is really important because it reduces stress erythropoiesis, which is the process where I described where a lot of red cells are getting lysed. The body wants to make more mature red blood cells, so that it keeps doing that and more cells keep getting lysed. And it reduces that if you're getting, you know, you have a transfusion regimen before. It also stabilizes the bone marrow before mobilization and reduces infection risk again, because a lot of these patients do have, I guess, impaired spleen function, right? And so, so yeah, one other change is the mobilization method. So plerixafor, I think that's how you pronounce it. It's an improved mobilizer agent. Mobilizing what, right? It's just mobilizing the stem cells from the bone marrow. So instead of messing with trying to get stem cells from the bone marrow, they mobilize it into the bloodstream so that you can just collect it through apheresis, and which is the method that they used in this trial. And they also do some conditioning. This is important because essentially you need to make some space for the new cells that you're going to give the patient so those cells can engraft. So they do myeloablation, which is less severe than what you would do for cancer, like irradiation or chemotherapy or something like that. So for that, they use busulfan, which is used for stem cell transplant as well. And as I mentioned earlier, it's the ex vivo or in vitro method, which is they take these CD34 positive or stem cells, they correct for the mutation using the lentiviral vector, essentially on a plate in lab, and then they infuse it back into the patient in this study using an IV. So this is what they did, right? They did the pre-harvest transfusion, mobilized the cells using plerixafor and collecting using apheresis. And then they isolate just the stem cells, which are CD34 positive. They transfuse these cells using the lentiviral vectors, which has the gene that we want. Once the transfusion is done, they do some quality testing. To prepare the patient for the infusion, they do myeloablation, again, making space for these new cells to engraft and express. And it's just an IV infusion. And after that, they monitor to see if there is a change, right? Does this work? And the cool thing actually is you really only need like 30% of these stem cells to produce the modified beta globin in order for the person to be cured of sickle cell disease, or essentially not have sickle phenotype. So, and one other thing they monitor for is efficacy endpoints, which is depending on how severe the patient is, it might take different amounts of time for them to reach a certain treatment effectiveness, right, or efficacy. Some patients might take a longer time for them to feel better, right? And these are just the different checks that they use. One is just monitoring for those severe vaso-occlusive events between 6 to 18 months after the treatment or infusion. They also, monitor hemoglobin levels, and they monitor for markers of hemolysis. And as I mentioned, right, these cells are getting lysed a lot in sickle cell disease. And if you see a reduction of that, we can say, okay, like this is working, right? One other thing, or some other things they look for, is also the vector copy number, which actually relates to the expression of the vector. So what a vector copy number is how many insertions of the vector we have in each cell. So like in any given cell, there might be one insertion of that gene, two insertions of that gene. It just, it relates to, do we have that modified gene in that cell, and how much of it do we have? And actually we don't want this number to be too high, because then it increases the risk of this gene getting inserted in a dangerous place, right? Like maybe next to like an oncogene promoter or something like that, and give the patient cancer. We don't want that. And I'll talk more about insertion of these vectors. And they also monitor for the expression of this modified globin. In terms of safety, they report all the adverse events that happen throughout the treatment. And they also monitor for clonal predominance, which I'll talk a little bit about. And it relates to this vector insertion. And essentially what that means is, let's say this gene that we're inserting, right, inserts in the same place over and over again in multiple cells. You might start seeing some other impaired, like some other problems, because if it's inserting inside this other gene that has some other function, right, it's going to impair the function of that gene. And if a lot of that is present, then we're going to actually have a problem. Like the person might get sick from something else, or get some other, have some other problem. So, but the nice thing is this only happens if the gene inserts in the same place over 10% of the time, which essentially never happens because it inserts randomly. So, but then they monitor for that to make sure that, it's not happening. In terms of the statistical analysis, there's not much in this paper, just because it's, again, it's unpre-specified, which is they didn't specify before the study what the method is going to be, and it's an interim analysis because it's ongoing. And the purpose is really just to inform the scientific community of how the trial is going. And so, and I also have the null hypothesis listed here, which was for them complete resolution of severe, severe crisis events in 40% of the patients. Okay, so now the results of, what happened. They did this therapy in 35 patients, right? And actually, one of them passed away, but the death was unrelated to the study. It was from cardiac arrest. And they followed the other, the rest of the patients for some amount of time, looking at the efficacy of the treatment. So about this treatment group, really, I want to highlight just some things. One, the fact that majority of the participants were Black, which is appropriate in this case because it's representative of the population that's affected by sickle cell disease. And some other things to point out with this treatment process as well. They monitor for if the cells that they delivered to the patient has engrafted, which essentially means that it made it to the bone marrow. It's expressing these healthy cells and not the sickled cells that were there before. And so they monitor for that. And they also monitor for the vector copy number, which I mentioned, which essentially it's just how many copies or insertions are there in each cell. And in this case, there was, 3.7 was the median, which is great. Like, it's not too high, but not too low, right? And then the percent of these stem cells that are transduced, which I mentioned earlier that you need 30% in order for it to be a cure. In this study, they had a median of 80%, which is amazing. And the lower end was 63%. And so definitely effective, right? Or you would expect, to see, efficacy at this point. Okay, so coming back to the vector insertion point. So we're delivering this vector into these stem cells, right? And they insert randomly. So one of the things that this research team did is they looked at where does this vector insert. So they had a region in the vector which they can use to track where it's inserting. And here's one example. So in one of the patients, they have this list of the top 10 insertions, right? And you can see the top frequency here is 2.6%. So, which essentially means that this vector inserted in this location this percent of the time in this patient, right? But this is fine because, one, it's lower than the 10% I mentioned earlier of this amount of disruption wouldn't change the phenotype of the patient. Like, it's still healthy and it's not causing any adverse effects, essentially. But it's important to monitor for this because, sometimes there might be an unfortunate situation where it inserts in a place where it is dangerous for the patient. If it inserts near oncogene, for example. But, in this study, that didn't happen. So now actually looking at the efficacy, right? So the first thing they looked at is vector copy number, which you can see it's sustained, as they're monitoring the patient, which is great, patients, which is great. They also look at this alternative sickle or alternative to the sickle beta globin expression, which is also sustained, which is also excellent. Then we actually have to see, okay, did it work? Like, did this therapy work, right? And really two main or a few ways they look at it. One is the hemoglobin expression, right? And here you can see that there is increased expression of the alternative anti-sickling hemoglobin. Even though, yes, there is expression of the sickle hemoglobin still, right? Because we didn't correct for it. We just added this new gene that's anti-sickling. But then, you can really see the phenotypic effect, right? You can see actually a large percentage of the red blood cells after around 6 months are positive for this anti-sickling globin and not the sickle globin. And so, and we can really see the phenotypic effects here because there's reduction of the key hemolytic markers. So one is lactate dehydrogenase, which is a marker for hemolysis, because actually red blood cells, one main way that they produce energy is through glycolysis. They're enucleated cell. And they also look at the reticulocyte count, which is the immature red blood cell, right? And it's reduced in this case. It's not in the normal range, which is these dashed. But then the lactate dehydrogenase and the bilirubin, which are both markers of hemolysis, return to normal levels. More than that, they essentially eliminated vaso-occlusive events for these patients. Like you can see in this chart, like these are all the patients here, and you can see the severe events that these patients used to have before the treatment and other events, right? And then after the infusion, it's pretty much gone for most of these patients, which is amazing. So we do see a phenotypic, almost curative effect from this gene therapy. 3 patients did have some adverse events related to this genoglobin infusion or LentiGlobin infusion, right? And they tracked for all that, and I'll talk a little bit more about that as well. So in conclusion, they expressed this anti-sickling globin in 35 patients, and they saw that it was effective. They were able to see this anti-sickling expression observed in most of the red cells, around 85% of cells. The markers for hemolysis were reduced. And they also saw that they were able to almost eliminate vaso-occlusive events, which is the main, I guess, primary phenotype of sickle cell disease. And in terms of safety, yes, 1/3 of patients, had some serious adverse events after infusion, but they were mostly abdominal pain, nausea, vomiting. There was no cancerous events from the vector insertion. And yeah, in 3 of the patients, it was related to the LentiGlobin infusion, and the rest, it wasn't related. Future directions, there are some limitations to this study given it's a small number of patients. There's no control group. And the follow-up was just, I think 24 months up to the max was like 37 months. But actually they're doing a 13-year follow-up study. So that's cool. We'll get more data from this as that goes on. But, in conclusion, this, 1 dose of using this gene therapy vector delivery of the lentiglobin, it resulted in a sustained production of this anti-sickling globin for the patients with sickle cell disease, and it was safe and had good efficacy. All right, that's it. I'm done. Any questions, guys?
Really good job.
Thank you. Isn't it a cool trial? Like I don't know if I'll work in gene therapy ever, but it's just so cool, and the amount of work that goes into these trials is insane. But it's a great start given that, sickle cell disease is a disease with, just a point mutation. And, we're starting to develop this technology, and, there are certain risks, but at the same time, a lot of smart people work on it, and we're doing good. But cool. That's all I have.
Cool. Yeah, I'm actually going to end it here. That was a longer presentation, so I'll save the ethical portion of this for the next journal club.
Cool.
But yeah, I'll end it here. So thank you, Priya.
All right. Yeah, sorry, it was on the longer end.
No worries.
Yeah, there was a lot of information, like in terms of like I wasn't sure how familiar people would be about like lentiviral vectors or sickle cell disease. And so like I had to give some background to explain what they did in the trial. So hopefully it was, clear to you guys, about the vector and all that.
It was good. Yeah.
All right, cool.